So I'm Alice Doyle, I'm HemiHelp's Chief Executive, and so HemiHelp, hopefully some of you already know a little bit about the charity. We're the information and support charity that exists to help children with hemiplegia and their families, and also for the education and medical professionals that are working every day like you people are to support them. So I want to just take a few minutes to tell you a little bit about what HemiHelp's doing for families and for professionals. First of all, I've just got a few slightly boring housekeeping notes. Fire exits are here, on either side. There's no practice fire alarm today, so if it sounds, then that will be real, so you'll have to leave the building. Please leave as quickly as possible and congregate in the front car park, so that's where you came in. Do not re-enter the building unless you have been advised to do so. There are toilets hopefully you found on this level, just outside, just on the right, where you have a coffee, and there's a safety and things out on both floors. If you want to smoke, please don't do that outside the front door. The designated areas are between the two pavilions downstairs, so if you ask at reception, they'll tell you where that is. And if you could not bring any food or drink into here, into the auditorium, that would be very helpful. And if you need assistance to get a taxi at the end of the day, ask at reception and they will organise one for you. And please don't leave your bags unattended. I just want to say a few thank yous as well to Daniel Goodread from Arrow. I'm not sure if he's here, but these guys have really supported this conference and helped to make it happen, so thanks to them. Thanks also to DM Orthotics and Dorset Orthopaedics, who are our sponsors for today. They've both got display stands outside, so do go and visit them and see what they're all about. We've also got a poster display outside, which belongs to Stuart Reed, who's sitting up there. He's a PhD student, and it's about support for adults with cerebral palsy. So go and have a look at that. And HemiHelp has an information stand outside, and we've got lots of information, resources, books. There's our new publication, which just came out last year, the Hemiplegia Handbook, which is co-written by Dr. Charlie Fairhurst of Everly Children's Hospital, and Liz Barnes, who's going to be speaking later on today, who's one of HemiHelp's trustees and is a parent of a young man with hemiplegia. It's the only book of its kind. It talks a bit about the medical side of hemiplegia, about causes and treatments. It also covers education, family life, how parents can deal with the emotional side of having a diagnosis and supporting a child with hemiplegia. It's really useful for families. I think it's also really good for professionals, for physios. And we do have a look at that during the day. You can take one away with you, or you can, if you want us to invoice you for that, then do that. So lots of you will know firsthand about the shock and the distress that families experience when they have a diagnosis, their child's diagnosed with hemiplegia. Lots of them will never have heard this word hemiplegia before, and they'll have no idea about what the future's going to hold for them. And that's where HemiHelp can step in and help to support them. And families tell us that HemiHelp's been a lifeline for them in terms of understanding what this condition is and knowing about the support that they can get, both from us and from other agencies and other services. So we really want to work with you to make sure that all families know about HemiHelp and know about the support that's available to them from the point of diagnosis. I'll just tell you a bit about some of the things that we've got to offer families. Information is the key thing, I think, really, and we're the only real source of the wide range of information about hemiplegia. It's available free on our website. It's accredited by the Department of Health with the information standards, so it's trustworthy, it's reliable, it's checked by information about education, about treatments, practical things like tying up shoelaces, things like family life, and associated conditions like behaviour, emotional problems, epilepsy, things like that. We can also link parents and young adults as well into the community of families who are living with hemiplegia. We hear quite often from parents the feeling of isolation that they experience because many of them won't meet another person who's living with hemiplegia. So through HemiHelp, they're able to come to events and to join local groups and meet other people who live near them, who are going through similar things to them, and really understand what they're going through, and who can provide mutual support to them. We're also somewhere they can go for help, so people who are in crisis, who are struggling with anything, any range of things, can ring our helpline. They can also access a home visiting service. We've got 2 home visitors who are here today, Amanda and Joe over there. So we cover the whole of England, Wales and Scotland. So they've got quite a big remit, but they do travel all over the place to meet families in their homes. They can also go to schools to help to educate teachers and support workers about hemiplegia and about the needs of those children. So we've got a new information pack available on our website. What we wanted to do is just to make it as easy as possible for you as professionals to be able to tell families about the support that's available to them. It's on our homepage at the moment. So it's also in the professionals tab. So if you go to the website, you can just click, download pack, print it off, hand it over to a family, and that's got a lot of information about what hemiplegia is, about some of the support that's available to them, and a membership form, and some information about HemiHelp in there as well. So do go in, have a look at that, and when you meet a family who has a child with hemiplegia, do pass that on to them if they don't already know about HemiHelp. In terms of what we do for professionals, we've got information resources for you as well. If you become a member, which is free, and you can sign up at the information tab today if you want to, that will mean that you receive our quarterly magazine, which has got information about the latest research. It's got a lot of parent experiences in there. And you'll find out about other events that we're doing, other conferences like this. We can also support research. We work quite a lot with professionals to help put them in touch with families so that they have access to people who can answer surveys or take part in research studies. So if you're doing anything like that, then do think of us and get in touch with us and we can help support you with that. I'm going to pass back over to Doug now. We've got a really fascinating programme today, so I hope that you'll all enjoy it. I really want to thank Doug and all of the speakers today for giving up their time. I know that they're incredibly busy, and Doug's already been at a meeting at 8 o'clock this morning before coming here, so thank you very much to all of you for making this happen. Enjoy your day, and do please give us some feedback. There's feedback forms in your packs. Tell us about what you think about today, if there are other things that we can do for you in terms of these events or anything else that HemiHelp can be doing to support you. Do let us know. Thank you.
Okay. So I think probably we need to get speakers to be relatively close to this, don't we? There's a mistake tackling it. So what I want to do, just to check who's in the room. So can the physiotherapists put their hands up, please? Okay, I think you might be a majority. Any occupational therapists? All. Some teachers. The odd doctor. And are they all? Anyone else? Okay, so we have a group of therapists, teachers and doctors. Okay, that's good to know. So the course of today is going to talk about different aspects of hemiplegia, but I'm starting today off with a slightly broader talk about an initiative which will roll out through 2013. And I just want to check actually, can I get onto the internet here? Will it let me do that? Yeah, it might be. Okay, so what I want to do is just tell you, because I would like all of those professional groups to think about being a member of the British Academy of Childhood Disability, which is what BACD stands for. And that organisation seeks genuinely to be multidisciplinary. And it has a strategic research group which has physiotherapists on it, occupational therapists on it, doctors on it, speech language therapists on it, psychologists on it. And that strategic research group we'll come back to. I also want to tell you a little bit about something called James Lind Alliance, which is an Ian Chalmers' brilliant idea. And Ian Chalmers has lots of brilliant ideas, one of them being the Cochrane collaboration. That was one of his ideas. And the James Lind Alliance is another. And then I want to tell you about a priority setting partnership, which is developing, and which is what I want you to be aware of for 2013. So this strategic research group of BACD was set up in 2008, and it has 4 aims. And the first 2 are here: identify and encourage high-quality clinical research in childhood disability in Britain, in particular collaborative multidisciplinary projects. So Pauline's going to tell us a little bit about a project she's doing in the West Midlands. Katie and I are involved with a brewing national study around treatments for drooling in cerebral palsy. And that really is the first test of a network of child development centres across the UK, which will be able to produce enough patients, enough children and their families, to get answers to research questions that you can't do in a locality or even in a region. And so we are, as a strategic research group, getting towards aim A. Aim B, in blue, to encourage and assist people in the field, including families, young people and clinicians, to identify research priorities. And that's really what this talk's going to be about, is how that BACD SRG is trying to answer that aim, or to address that aim. The third and fourth aims, or C and D, are here: to facilitate and support the development of major research applications to the big funding agencies, to do really high quality research, and to encourage young clinicians from whatever background. So there's an occupational therapist with an MRC grant working in Aberdeen at the moment, which is on the SRG. She's really amazing. And there's another occupational therapist called Anne Gordon on that group, who's amazing. And so if you're an occupational therapist and are wanting to develop a research idea, you'll find on the website the contact details of these people. And if you're a physiotherapist, Teresa Bolton is a member of this group, and you can get hold of her for your research ideas. And there are some doctors on the group too. So there are some links for people who might be interested in pursuing research in the various groupings. So this is a bit of the website of BACD. When you put BACD into the Google machine, you get the British Association of Cosmetic Dentists, and then you get the British Association of Cricketers with a Disability, and then the third one is the British Academy of Childhood Disability. And so this is the web page, and I'd encourage you to have a look at it. And for those of you who'd be interested in little bits of snippets on research, there are some bits there: starting out in paediatric research, how to fund a research project, expanding research capacity, and the research environment. Okay, so let's go back to that aim 2, the one in blue: to encourage and assist people in the field, including families, young people and clinicians, to identify research priorities. So that was written in 2008, before we were really aware of the James Lind Alliance. Has anyone heard of the James Lind Alliance? Yeah, that's because you heard the talk before, wasn't it? I thought you probably anyone in the room had heard that talk before, so that's a relief. Here we are, the James Lind Alliance. And her picture will come a bit later, but I borrowed these slides from Catherine. She doesn't mind. She said I can do that. And so what Ian Chalmers' idea was that research questions need to be more democratic. They need to involve the various different groups of people who are impacted by the problems. And so we need to really find out about research that's important not just to researchers, but to children and their parents, their carers, and clinicians. And the reason why this is important is clear from this slide. So if we have down here in red the patient's priority, what patients think they need to have more information about or more research to know what to do about, is in red. And what the research community is doing in terms of trials is in blue. So we can see that the trials are done on drugs, primarily because the drug companies sponsor the trials. So there's an awful lot of drug trials. Families are less interested in that. Families actually, in this context, this was an orthopaedic subject, wanted to know about hip replacements. There are very little in the way of trials on it, but that's what the families wanted to know. They also wanted information, research on effective education and advice, much more than the research community was doing. And the patients had a group of other things they were interested in, which the researchers weren't doing anything about. Now, people have approached this sort of conundrum differently. Another person whose picture is going to appear, because he's on this group I'm going to talk to you about, is Chris Morris from Exeter. And they have a Cerebra unit. Cerebra is an organisation, rather like HemiHelp, that does commissioned research around cerebral palsy. And the Cerebra unit in Exeter only does research which has come out of their parent advisory group. So they only do the red ones. They won't do anything unless it's come out of a parent support group, which is a very interesting approach. But the JLA was an effort to try and formalise this involvement in developing research questions. And so it created a methodology to do this called a Priority Setting Partnership, a PCP. So that's pneumocystis, PSP. and that involved patients, carers and clinicians. And these partnerships have been usually focused on a single condition, and I'll show you a few in a minute. So child with disability is somewhat different. That's a much broader term. That's not a single condition. And it seeks to identify uncertainties about treatments. Many families might think things are uncertain, and it might be that actually we know. I'll say that's fairly unlikely. The process seeks to identify uncertainties and then prioritise the most important ones. So you end up with a top 10 list. And so here are some partnerships which have been working earlier than the one I'm telling you about. So they've been completed around asthma, urinary incontinence, vitiligo, prostatic cancer, and I think the cleft lip and palate, which involved the one of the surgeons from the Children's Hospital in Birmingham. I think that one's almost finished. But you can see that there's only about 15 or so. So there's also a lot of medicine untouched by this process as yet. And then it goes through a series of interlinking steps. So there's a steering group set up. Partners are invited to be part of the process. And now that's kind of why I'm talking to you about it today, because HemiHelp could register as a partner. You could register as physiotherapists or occupational therapists to be a partner. Then there will be a process of gathering uncertainties. There will be a mail out in 2013 asking what families, which are linked to this process, hopefully through HemiHelp and other organisations, clinicians, think are important questions of which we don't have an answer. We gather those up. We are expecting quite a lot. They generally are in the several hundreds to 1,000 or two. We aggregate them because they may well be the same question asked in different ways. We see if they are genuinely uncertain by going to the literature. And when we have the genuinely uncertain uncertainties, we then go through a process of prioritising those. Now, the steering group is important because it sort of drives this process, and it's got patient representation, or family representation, and clinician representation. And it's developed a protocol. And this isn't on your slide, that last bullet point. I'd quite like you to write that bit down, because if you write down that web address, you'll find that it gives you more information on this process than I would if I'd got internet access to put it up for you now. But because I was worried on mine, I've nicked some bits on the next few slides from the web page. Am I safe to move on? So that web page will tell you quite a bit more about the process. And on it, it'll tell you about the people who are on the steering group. So here's Mary. She's from the National Network of Parent Carer Forums. So over here we hear that she moved to London 20 years ago with 3 children, 14, 12 and 10. The process of diagnosis for her now 12-year-old severely learning disabled son was long and negative. She did not make clear what his needs were. She had to create pathways to diagnoses and care herself. Now, none of us who were in this train want that to happen, but it's of course a common experience. Recognising the negative impact battling has on families and the benefits of prevention and early intervention, she works with like-minded parents through her local parent carer forum to push for changes needed in culture and ways of working in health, social care and education to deliver quality integrated services. She's also the London representative on the National Network of Parent Carer Forum steering group. And she got a little quote: "I'm delighted to be involved in this important work for the benefit of children with disabilities and their families. Particularly like to see the same media interest and attention given to research outcomes and priorities for our children as currently is the case for other patient groups." She's quite vexed by the fact that the cancer, it's important cancer gets attention, but often cancer or stem cell research or something like that gets on the Today programme. You very, very rarely see issues around children with disabilities on the Today programme. You never see, what's his name, Kieran Walsh, or not Kieran Walsh, but something Walsh, of their sort of medicine correspondent talking about disability. Fergus, that's his name, isn't it? Fergus Walsh. He's a nice guy. And then here's a second patient representative on the steering group, Anna. Lives in Cornwall. Got a daughter, Susie, Joe, and 13 and 15-year-old sons, Herbie and Matthew. Susie Joe is born with a range of conditions affecting sight, mobility and learning, has prosthetic eyes, registered deaf-blind, uses a wheelchair to get around, a number of diagnoses with cerebral palsy and autism. Also has septic optic dysplasia, which affects her growth, and she's on growth hormone. She attends a specialist college with integrated program of education, social skills and therapy. So you see to the personal budget, and we arrange all her care support while she's at home ourselves. Anna is in the last term at the Southwest representative on this national network of parent carer forums, runs her own training consultancy company, involved in a range of projects relating to disabled children, young people and their families. Also a lay member of the Nursing and Midwifery Council, sitting on their fitness to practice panel. Delighted to be joining the Priority Setting Partnership for this research project with the JLA. Hope that some of my knowledge and experiences, both personal and in a wider context, are helpful in helping inform this piece of work. And then there's Catherine, whose slides we're nicking. And she's the chair. She's been working with the James Lind Alliance for 5 years and has worked on a number of these priority setting partnerships, so she's helping us through the process. And then we have Mark, who hasn't got a photo on the website yet, and he runs the UK database of uncertainties around the effects of treatment, what's called the UK Duets, which is part of the NHS library. And so that'll be part of how we go to the literature and identify what's uncertain. And then Amanda hasn't written a piece, but Amanda is also on this steering group, and she's works for the Council for Disabled Children. And that's kind of an umbrella organisation to which you may or may not be a member as HemiHelp. You are. There's about 100 organisations, and we expect through that and Contact a Family that many parent support groups will become aware of this piece of work using Facebook page and other new media that Amanda's very good at. And there's my mate Chris. who leads, as I told you, this Peninsula Cerebral Research Unit, a broad range of applied health service research aimed at evaluating ways to improve the health and well-being of disabled children and their families. Many years' experience working with children and families as an orthotist, that's what he did. We went off and did a master's degree, and then did a PhD in Oxford, and he's a fantastic guy. Chris is part of the SRG of the BACD, and it was his idea, initiated the idea for this price-setting partnership after Catherine came and presented to us. It's so fantastic to be starting out on this project after all the proposing, persuading and planning. It's really great to identify the top 10 research ideas that are important to both families of disabled children and clinicians who will make a difference to children's health and well-being. So he's pretty motivated. Then there's me. I'm keen to join this Brighton partnership because I think it's an excellent way to identify the most important research issues in child with disability. Okay, so we've got that group's set up, and we've been meeting 2 or 3 times, and we're just about to be inviting partners, and that's really going to happen, we think, in January onwards. So that's why I want you to be aware of this. And so you can be a partner, and you can put in questions, and you can tell your mates, and they can put in questions. There will be a web page that you can write down your questions to, and you can link at it through that website with PSP at the end. There will be a press release, and there will be other ways of accessing people. You have to declare any interest you've got and who you're affiliated to, and there are some exclusions, but I don't think any of you would meet those. So, what's an uncertainty? Well, by that we mean that there's no up-to-date, reliable, systematic reviews of research evidence addressing the uncertainty about the effects of treatment. Okay? Or that an up-to-date, systematic review of research evidence shows that uncertainty exists. Either of those constitute an uncertainty. Okay. There was going to be a big piece of work in the middle of 2013 for which I'm going to come to some of you, and I'm going to come, we've got a number of master's degree programs around the country where we're going to use the masters as students as part of their projects to systematically review some of these questions that are uncertainties to identify if they genuinely are uncertainties. That's going to be quite a big piece of work. We've done this. This is done on a shoestring. So most, this feels like this should probably cost about £200,000 to £300,000. It's being done on £20,000, and there's no money for any of the professionals, and the universities that Chris and I work at will frown upon this if we told them, so we don't tell them, because we're not getting paid. But it's the only way we get this done. And the £20,000 came from the Paul Polanyi fund, which sits in the Royal College of Paediatrics. So we'll then have, when we've got all these uncertainties, we'll have 2 stages. And in this interim stage, where we go from a long list, probably a very long list, to a short list, top 10 uncertainties chosen by partners as individuals, on behalf of members, on behalf of colleagues representing an organisation. And then we'll have this nominal group technique day, where which Catherine's done quite a few of. Apparently you all have fisticuffs, and then you storm and then you norm, you all make up at the end. But no, I want that in, I want that out. What are you doing that for? No, yes, oh, okay. So it's a democratic discussion and ranking, and we prioritise the remaining uncertainties, and we all the way down, but we agree the top 10. Now you might wonder why on earth we're going on and on and on about the top 10. And the reason is that rather like child with disability doesn't get onto the Today programme, or Fergus Walsh doesn't report on it very much, the funding bodies also don't fund very much research in this area. And the James Lind Alliance is now based in Southampton in a building called NET SCC. That doesn't matter to what it stands for, but it basically is the commissioning part of the National Institute for Health Research. So what we've got is James Lind Alliance sitting down the corridor from the people who set the research questions to be commissioned and have the budgets to pay for them. So what we anticipate, and this has happened for the other JLA priority setting partnerships, is that NIHR picks up the top 10 and starts to commission research around those issues. So it's a strategic way into getting these things commissioned. And also, you could all know what the top 10 are going to be and start working on research questions, so when it comes out you've got a proposal ready, because there's often not much time. So where we are in the process, this is the process summarised for you, is that we're really quite near the top. We've established a steering group of patients and clinicians, and we're awareness raising amongst patients and clinician groups. And we're about to be recruiting. I would hope HemiHelp would be a partner in that process and would register and would, through its network, disseminate this out to families so families can put in uncertainties that concern them. Okay, so just to go back to that slide again, for one of our 4 strategic aims, to encourage and assist people in the field, including families, young people and clinicians, to identify research priorities. We think we found a methodology to do that. It's worked for other disease areas. It is slightly more complicated doing it for neurodisability, but we're on the road and we want you to be part of the process. Okay, I think I've told you that. So, what is your role? From today, think about uncertainties. What is it that vexes you? What is it that you wish within hemiplegia from today, or in neurodisability if that's a part of your work more broadly? What is it that you think we should be pursuing? Publicise this process with people you come across. I would find it very helpful if you feel you've got systematic reviewing skills, and you're on the, have you done Eureka? Okay, then you're on my list. If you've got systematic reviewing skills, I would be very keen to hear from you, because you can be part of my crew, and I need a big crew. I think I probably need 30, 40, 50 people who can take groups of 10 questions and go through them and say, yeah, we'll give you clear criteria, we'll tell you what to do, and you have to go search everywhere. It'll be on duets and probably PubMed, that'll be it. But yeah, that's an uncertainty, or no, we've got an answer to that. Okay, so I've told you a little bit about the Strategic Research Group. I've told you that BACD stands for the British Academy of Childhood Disability, even though the quality dentists are higher up, and that you should join. You occupational therapists should join, you physiotherapists should join. You have within your disciplines, I'm a bit less sure about the teachers, I'm not sure about that, but I'm slightly, why not join? It'd just be a challenge to us. But there are people certainly within the therapy domains who have got a research background and are keen to assist any of you who are interested in developing research. I've explained to you a little bit about the James Lind Alliance, and I've introduced this price-setting partnership to you, and I do hope you will get involved with this. It will run through 2013, and I imagine we will be giving NIHR those top 10 about Easter time 2014. Easter to summer about summer 2014. Okay, now we're not going to take any questions now, because it says we're going to have a question and answer session after you. So we're going to have a pause now. If you've got any questions, feel free to write them down, and then Pauline and I will try and answer them in a few minutes. Can we begin?
Hello, good morning. Can you hear me back? Nice to see several familiar faces in this time. So I'd like to tell you about a trial I've been involved in doing. To start with, I'll give you a little background about the intervention that we used, and then I'll tell you about the actual trial. As for the title, I haven't actually got any results for you, I'm afraid. It's still ongoing. But if I'll give you an overview of that trial. So first of all, just a bit of background about hemiplegia. I'm sure you all know this. Approximately 30% of children with cerebral palsy have hemiplegia, so it works out about 3,000 to 4,000 live births. Of those children, impaired arm and hand function are the main problems in about half, and main factors interfering with activities of daily living. But hand function may be affected by a number of different impairments, and there's a bit of an overview about them. So we're obviously aware of spasticity, and it's something that we are often intervening with. But there's also weakness, which I think is dealt with more so than it used to be therapeutically. Poor selective motor control, i.e. it's quite difficult for a child with hemiplegia to actually identify or separate parts of their hand out, so moving their limbs, the parts of their limbs separately. Disuse because the hand's not being used. We sometimes see mirror movements. Okay, and another area that affects opening control is developmental disregard. Now this was described by DeLuca, and this is where, because it's quite difficult to use the affected upper limb, the child learns to do skills and becomes very adept at doing skills with one hand. So why bother using both hands? So you get what's called developmental disregard, or learnt non-use in the adults. Okay, and also that will also impinge on development of hand skill, the effective hand. Okay, so constraint-induced movement therapy. I first heard of constraint-induced movement therapy literature. I read a bit about it, and as a consultant physio, was able to implement, I was supposed to be trying to implement evidence-based practice. And thought it might actually be useful to have a go at using it with our patients, because one of the things that we really struggle with as therapists is to get any carryover of our intervention. So we might be working with a child in a session and find that you get some good results in the session, but actually out of the session it's quite difficult to get any carryover. So it seemed like constraint-induced movement therapy would offer some impact on the child as a therapy session. It's an unusual intervention in that it's about, if you like, it kind of has its history in behaviour rather than in therapeutic intervention from a kind of physio-OT perspective, from the motor impairment perspective. And the idea is that it creates opportunity for the child to explore and use their affected limb. And this experience is thought to reverse the behaviour of suppression of the affected limb. So the idea is that you get this developmental disregard. Well, actually, if you're encouraging the child to use their affected limb, you can potentially get suppression of that developmental disregard, which is in contrast to traditional therapies, which tend to focus more on level of impairment, thinking about the different impairments that you get. So generally, therapies tend to focus on trying to improve sensation or reduce spasticity or strengthen, whereas this is much more about trying to get the child to use their affected limb, whatever the impairments. So the focus is on the actual activity. Okay, so as I say, the foundation is in behaviour research rather than in motor impairments. It's about overcoming the non-use of the affected arm, it's thought, the concept is thought to be based on cortical areas of reorganisation following the use of the affected upper limb. Could be. Okay, so what is constraint-induced movement therapy? Well, as I say, it is more about trying to get the child to use their affected upper limb. So rather than it being doing to the child, the idea is that you actually try and sort of have an effect on the environment. So the idea is that you take away what the child is using, which is the unaffected upper limb. Okay, so it's a combination of mass practice activities with the affected limb and in combination with restraint of the unaffected upper limb. And it is considered to be an effective upper limb extremity in adults and expected to include ADL. Now, in terms of systematic reviews, there has been a systematic review carried out, and it was published by Hall in 2007 on the Cochrane database. And as you can see, there's only 3 studies that have been included in the Cochrane database, and only 2 RCTs. So the middle one, the Eliason one, was a clinical control trial, so the patients weren't randomised to either arm, which kind of does actually mean that study, because the patients weren't randomised to a group, you can imagine that patients, the family's approach to this intervention will have quite a big impact on how successful it is. So if you can choose which arm the patient would go into, that would negate actually the impact of the actual constraints. So looking at these different approaches kind of gives you a bit of an overview as to the different approaches that are currently available. So DeLuca really represents Edward Taub's approach to constraint-induced movement therapy. Edward Taub is an American psychologist, and he would, and really constraint-induced movement therapy was his invention, if you like. He did lots of work with primates in the 70s and 80s. And that approach to his approach to constraint-induced movement therapy is about doing restraints 24/7. So the restraint would go on and it would stay on permanently for a period of time. And during that period there would be intensive therapy practice. As a Taub is a psychologist, so the type of practice that would be carried out was something called shaping. So nothing would happen to the patient, but the task would be very carefully thought through. It would gradually be increased in terms of challenge. And there would be, with that particular intervention, there were 6 hours per day of therapy, face-to-face therapy. Okay. But obviously, it showed some good results. The Eliason study represents a different type of approach to constraint-induced movement therapy. They did restraint on a part-time basis, so they did a couple of hours of restraint per day, and their type of intervention, Eliason's an OT. Have you heard of Eliason? Yeah. She's an OT, and their type of intervention would be based on motor learning theory, so the sort of intervention that physios and OTs would look at using. So generally encouraging use of the affected limb with tasks. And Simkiss is a bit out on the limb in a way. What he did was did put the restraint on for 6 weeks continually and didn't offer any particular therapy alongside that. Okay, so in a way that's the only evidence that we have to underpin trying to use it in our practice. I did actually email Barnhorn. He's repeating the systematic review which was done in 2013, but in a way that says, because normally they should be repeated every 2 years, and that was done in 2007, so there's not an awful lot of more evidence out there either. So I was interested in using this in practice, and so carried it out on a child. I'll show you the video of the child that we used it with before I then go on to tell you about the actual trial. Okay, so this is Jamie. Now And when we started this intervention, Jamie, who had meningitis at 6 months, so this is him now age 2, okay? And I asked Mom to just do some basic videoing of him at home. Not particularly, just taking snippets of him at home, okay? Playing. So you can see here, he's got a diagnosis of a left hemiplegia. Okay. So if you notice how little he's using his affected hand, the kind of flexion of his shoulder and his elbow, and notice he'll start moving in a minute, and just notice what happens to his wrist as it starts moving. So you can see the increase in flexor spasticity in his wrist. So he's not only not using that hand, we're seeing some quite increasing sensitivity actions as he does move it. And then this is him feeding and not really using his affected hand. That's his brother. In this video, he's got a little cube in that left hand. You can see there's a lot of increased flexion to hold it, but as it drops out of his hand, it doesn't really engage. He's not really engaging with the use of that hand. Now this was the first attempt at using constraints, a bit of a Keith Robinson type plastic, because we weren't quite sure how to do it. But you can see he immediately starts using his left hand. Difficulty supinating, so he helps with his right hand. When we actually did this movement therapy with Jamie, he had been crawling for 6 months. This is a better plaster. We got the plaster in. This was when I was working at Stanford. It's a Stanford child. It's the technicians at Stanford to put the plaster on. Slightly extending the wrist, so he got something to weight bear on. And this is quite an interesting bit, because if you notice here, he's obviously trying to place the object in the shape. Now with this one, places it in, you can grab it quite well, but as often is the case, he can't let it go. He has a problem with active release. And then he tries again, and he tries to open his hand a little bit, but still can't manage to do it. And I knew exactly what he couldn't do, but you see, if he'd got his good hand there, his good hand would have come along and taken it out. So if you like, what the constraint was doing was pushing him in to an area where he wouldn't normally go. The instructions that were given to Mom were that just don't do anything specific with him, but give him lots of toys that he can just access easily around and about. One of the criticisms of constraint-induced movement therapy is that how can you practice unilateral skills and expect bimanual skills to improve? But you see, because of the method of restraint that was used, he can still use both hands. So here, he can still use both hands together. They're still coordinating together. And it was easy. It was easy. It was fun to do. And you can imagine the intensity of practice. that he had. Now this is him, this was the last part of the video, this was him just before he started nursery, so about a year after we started. And if you like, the idea is that we got him ready for more formal education so that he could use his hands in a bimanual way, and you'll see how much more spontaneous his hand is.